Hello. Hi, everybody.
Hey.
I think we might get a start now. Thank you, everyone, for joining us. My name is Christina, and this is Kerry, and we're both from Craniofacial Australia. We are a not-for-profit charity dedicated to supporting and empowering people with craniofacial differences and conditions. And I wanted to welcome you all tonight to our final webinar. And it's been an absolute pleasure having you all for the last four webinars. I've really taken a lot out of it, and I hope you have too. And just before I pass you over to Dr. Boyce, I wanted to acknowledge and thank PKF Foundation Adelaide for generously providing a grant for us to set up this program. And without further ado, I'll pass you over to Dr. Boyce.
Amazing.
Thank
Thank you,
you.
Christina.
Thank you.
And here we are at our last session in this series. And we're going to talk about, I'm going to be talking to you today about an area that is talked about a lot in the cleft world, and that's speech. And this is often something that comes up when you mention cleft, people often are asking and wanting to know more about speech. So what I'm talking about today is relevant for children, adolescents, and in some cases adults in relation to how they sound when they talk. And what I'm going to do today is describe different components of speech and how speech might be affected when someone is born with a cleft. And I'm going to cover as much as possible to give you a good base of understanding around what's happening. But I want to also be really clear that I'm not prescribing any particular exercises or activities in what I'm talking about today. That will be the role of your speech pathologist, and definitely a lot more individualized discussions and work together with you and your child or your child. So I just wanted to be clear around that distinction today as well. And one last thing I wanted to clarify before we get into some content or specify is that we do have studies and good evidence to say that speech therapy that is implemented at home from a parent or a primary caregiver has good outcomes, which is really great and really wonderful. And that supports a lot of different types of models of care, like telehealth, for example. And the first step in this process is education. So it's having education sessions so that you, the people who might be delivering this intervention, have a good understanding of what's actually happening with your child's speech. So you can then talk about it together, explain it, and then support them to make any changes that you might be working towards. So I'm hoping that today will contribute a little bit to that education. So you've seen this slide before if you've watched or attended any of the previous webinars. So this is a quick refresher and reminder of what the role of the palate is in speech. So we need our soft palate to rise and close off and make contact with our posterior pharyngeal wall to separate our oral cavity and our nasal cavity when we're talking. Most of the sounds that we use in English require that tight closure so that all the air and sound is directed out through the mouth. If the palate's not working so well, that's what we call, or if this closure is not being achieved adequately for speech, then VPI or velopharyngeal insufficiency might be present. And that's the term that we hear a lot, VPI, VPI, VPI. The structure of the palate, so even a little bit more towards the front, the hard bony part, can also impact the clarity of sounds too. And of course, hearing plays a really important role. We need to be able to hear, to be able to then process and then learn how to say different sounds and different words. So what does cleft speech actually sound like? This is where we start getting a little bit technical, but it helps to understand. I'm hoping it will help you understand what is happening and what your speech pathologist is going to be looking at when they are assessing your speech or your child's speech. So when we're thinking about speech and we're thinking about cleft, we're thinking about the palate, we're interested in a few different things. We're interested in where the sound is traveling and where the air is traveling. So is the sound and air traveling out through the nose when we actually want it to be traveling through, when we actually want it to be coming out through the mouth? And it might be coming out, as you can see with these arrows, it might be coming out from the back of the mouth because that palate is not getting that tight closure, or it might be coming out through any fistula or holes that are in the palate. And sometimes we see fistula develop as children grow. So sound and air can also come out through the fistula. So if we have extra sound coming out through the nose, we call that hypernasality, and that affects the underlying tone of how someone sounds. It can also affect how well someone is understood. And then if our air is coming out through the nose, we might hear some rustly sounds accompanying or replacing talking. And these are sounds that are fairly unique and specific to people who have a cleft. So it's hard for those sounds to be imitated by people who don't have clefts. But it sounds something like this, accompanying those speech sounds. They're both related and they can impact each other. The main message here so far is that we're thinking about where the sound is going and we're thinking about where the air is going. And then the other thing, of course, is articulation. So where is the tongue, lips, and teeth? Where are those different articulators sitting? Where are they placed when someone is talking? So when you go in for a speech pathology assessment, whether that be at your tertiary center or out in the community, it's the speech pathologist is going to be trying to work out what's happening with the speech. Where's the sound going? Where's the air going? Where are the lips and tongue and teeth placed for different sounds in different words in different contexts? So if from an assessment where the speech pathologist has listened to the speech, had a look inside the mouth, if they think that VPI might be present, then they may suggest further investigation. And this step usually will happen at the tertiary hospital because it's a little bit specialized in the sense that we need to be tuning into specific cleft-related things to then make the call to say if we want to investigate this a little bit further. And the way that's investigated further is to actually have a look at what's happening at the back of the mouth. So that might be with a camera that goes down through the nose and just sits right at the top of the soft palate towards the back. And then that allows visualization of what's happening at the back while speech is happening. Or it might be through a moving X-ray from the side while speech is happening again. And the reason why further investigation is important and is needed here is because if VPI is related to something, if the speech difficulties are related to VPI, which is related to something structural, then that may lead to further surgery to better support speech. And this further investigation usually happens somewhere between 3 and 6 years of age. And that's because we want to be hearing a lot more of that speech, a lot more of that talking and language sample to be able to confidently make decisions around what's happening. So we need to have more speech to hear to determine how any structural differences are affecting how that speech is sounding. And we need cooperation to complete these assessments. So we need a child to be able to sit and follow instructions, repeat what's being asked, and go through that assessment. They don't generally take very long, but we do need that cooperation and we need that language sample, the speech and language sample. So let's tease out this articulation section a little bit more because there's lots happening here, and it's helpful to understand why we might need surgery versus what we may be able to treat with therapy. So when I'm talking about articulation, I think it's a term that's fairly familiar to most people. What I'm referring to is sounds produced in error. So that can affect someone's ability to be understood. There are two broad types or categories of speech articulation errors that we see in individuals who are born with clefts. The first is mislearned patterns. So this group is also called compensatory errors or active errors. So these are terms that you might be familiar with, you might have heard of, definitely terms that us as speech pathologists will be using. What these are is that they're changes in articulation that are developed in order to compensate for structural differences. And they happen naturally in the sense that your child can sense or knows something is affecting the way I'm able to say that sound. So I'm just going to put my tongue in a different spot because that helps me say a sound that I can control a little bit more, that can help me then get this word out. So there are changes in articulation that are made in order to compensate for structural differences. Sometimes these patterns become habits even once the structure is adequate or appropriate enough for the child to produce the sound in a target that's closer to where we want it to be for their speech to be understood. So what I mean by that is that they're physically able to produce the sound, but they've been practicing saying it in this compensatory way for so long that it's become a habit, and that's how they say that sound. So these are the ones that we can treat with therapy. And what we're doing is retraining how we say those sounds. And for any speech pathologists who are here or watching or listening, these mislearned patterns are articulatory in origin, but they have phonological consequences. So that's a really important thing to keep in mind because that changes how we approach and might address any therapy and intervention. So these are the ones we can treat with therapy. These are the ones that we can start to address as soon as able. Even if speech surgery is planned, we can still start working on these types of patterns and errors before the surgery happens. And these ones are the ones that you can support your child with at home as well. If these articulation difficulties are related to something structural, so if VPI is present, so the assessment with the camera down the nose or the moving x-ray has happened, and we can see that something's happening structurally. So the closure at the back is not perhaps as tight as we would like it to be. Something else is happening. That's not something that we have much evidence, if any, to say that we can treat that with therapy. So that's what would then lead to further surgery. The teasing out of these happens in a tertiary center. Decisions around all of this happens in a tertiary center. But the therapy and the treatment for these mislearned patterns, that can happen anywhere. So that was a lot of information, a lot of technical information. Main takeaway here is that some speech errors can be treated with therapy. Some speech errors will require surgery. It's the speech pathologist's role to work out which is which in collaboration with the surgeons as well. But these are the two things to sort of keep in mind. So let's talk a little bit more now about the errors that we can treat with therapy. So what can we do? So therapy for these patterns that are mislearned is about learning how we want to produce these sounds, adjusting the lips and tongue and teeth to put them in the right spot. So on this slide, I've got the different parts of the mouth and the oral cavity and the sounds that are produced in that part of the mouth. So these sounds, are all produced with our lips and teeth and the really front part of our tongue. And then as we start moving back, we've got these sounds here, sh, j, ch, and then sounds right, using the really back part, the furthest back part of our tongue, and also down sort of more in our throat area. K, g, and uh-oh, that sound at the start, that. Now I've got this here because I want you to, if relevant for you, think about where sounds are produced when for any sounds that your child is struggling with, because knowing where they're produced then gives you the words to talk about how we might change that production to move it into the place we want it to be. So an example might be that your child is saying, instead of saying I sat down, they might say I cat down. So I might be talking about moving the sound towards the front of our mouth. And I've got a few things on what we might actually say on the next slide. This last point here is sounds that are actively pushed through the nose with friction. So this is a error that we see specifically in children who have a cleft, whereas sounds are pushed through the nose. And I've flagged that here because we talk about changing where that sound is going, moving it from coming out from the nose to coming out from the mouth. These are things that we talk about. So what we do with these patterns is really, the therapy is really about retraining the muscles, retraining the patterns. Now I have whole lectures going through what I've got on this slide. So take what is useful to you and leave the rest behind, and just take the one or two pieces of information that are useful to you here. The other thing I wanted to talk about and just touch on is that we have different ways that we say the sounds that might affect our understandability, but sometimes we might not be aiming for the quote unquote textbook production of sounds. Our goal might be more around making speech more intelligible or more understandable by other people, which is a really valid and great goal to have. So that's something that is important to think about and be aware of, I suppose, when you're thinking about your own goals for your child's speech, and also when you're having conversations with your child about their speech. What I mean is that we might be teaching them to say a sound that helps their speech to be more understandable, but the way they say the sound might still be a little bit different to how someone else their age who doesn't have a cleft says that sound. So if we know what errors are present in a children's speech, we know which sounds they're having trouble with, we can then start to talk about how they can change the way they say those sounds to make their words and their talking more understood, more easily understood by other people. And how do we do that? We talk about the sounds as one thing we can do, and we do therapy. And that's what we do. That's what you can be guided through with your speech therapist. So what might we say about different sounds? So the sounds that are being pushed out through the nose, it's as simple as saying, I want the sound to be coming from your mouth, not your nose. For those front sounds, using lips and tongue and teeth, I might be saying something like, my tongue is between my teeth, and then showing it. My tongue is up behind my teeth, right behind my teeth. Move the sound from the back of your mouth to the front of your mouth. So it's not uncommon for us to see children who have a cleft saying lots of sounds in the back of their mouth, because they can control that, because those sounds happen before the air and the sound reaches where their cleft is. So often we're talking about moving those sounds from the back to the front of the mouth. And sometimes it may be helpful just to get that feeling of what it's like for sounds to come out of the mouth, to hold the nose and then open it. But this isn't something we want to use too much or a lot, because obviously that's not what we do when we're talking. We can't be holding our nose every time different sounds come up in words. So these are some of the things we might start saying. And it's the speech, you'll work together with your speech pathologist to work out which sounds to work on. If there are multiple sounds that are a bit challenging, which sounds to work on first, and then lots of other tips and tricks to produce the sound. So these things I've got here, the words, the things we describe the sounds with, that's only one way that we can support changes in this way that sounds are produced. And this is my last content slide about therapy and what we might do. And this is an overview on, once we work out which sounds we're working on, how we're going to work on those sounds, what do we then do? It's all about repetition. Repeat, 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 repeat. It's just like if you imagine learning a new exercise at the gym. If you've been doing push-ups one way your whole life, and then you get a personal trainer and they say, actually, you need to have your arms in a slightly different position and your elbows tucked in. You're going to have to practice that a lot every day with that prompt in your head, hands like this, elbows in, before you're going to be able to do that correctly. Thinking about retraining those muscles, that's the same thing, essentially, conceptually, what we're doing when we're working on these kinds of speech sounds. And the thing that's tricky with speech is that we're talking all day, every day. So in between our practice sessions, our times of practice every day, we revert back to our old way of saying the sound. So this repetition and this support is so important. But that also means that motivation is really important as well. Motivation from the adults supporting the child, but also the child. It really has to come from them. They have to want to work on it. They have to be willing to put the time in to see the results. And if they're not, that's okay too. It's totally fine. If everyone's fine with how the speech is sounding, they're okay. They're not feeling upset about it. It's not affecting their confidence. They don't want to work on it. Totally fine. Very acceptable. Not to work on things just because they're present. And that's always something that I talk about really early on with families when we meet in a clinical context. And it might be that you have identified these things that are happening now. Now's not the right time. You come back and revisit it at a later point in time. That's really totally fine as well. And if not, and in some contexts, it's better to wait if the motivation isn't there at that particular moment in time. And I touched on this before, but any speech therapist who has experience working with speech can support in this area. So there might have been an assessment in a tertiary center where specific sounds have been identified, a more cleft specific assessment has been completed. The therapy can absolutely be administered by any speech therapist who works in the area of speech. So last thing here is to flag a few things to keep in mind around when you might want to go and might be worth going to see a speech pathologist. And these things will be relevant from around 3 onwards, but it's going to depend more on how many words your child has. So as they're starting to speak more in sentences, longer sentences, 3 to 5, or even longer words, these are the kinds of things we're starting to think about. So if they're difficult to understand most of the time, especially by you as their primary carers who know them really well, if they have this quote unquote nasal speech, and I think you will know what that is if it's present. if they have a limited variety of consonants or they're using any unexpected sounds, so those sounds that are perhaps coming out through their nose with that friction, definitely worth looking into that a little bit further. And then the other things which I haven't had a chance to explore in too much detail today are the broader effects of differences in speech. So if you feel like they're talking less or avoiding talking because of how they sound, or if they're frustrated with their speech and it's affecting other parts of their being or their well-being and how they're feeling as a person, definitely worth going to investigate that further. Okay. And this is the slide that I've had at the end of every session with some services and supports and places that you can go. Oops. Hospital clinics, main regular check-ins and point of call, and for community speech therapists as well. Someone asked a question in the last session about supports for speech pathologists supporting children after surgery. And I was thinking afterwards that I didn't mention that the tertiary speech pathologists are a great resource. And they're more often than not, I'm sure they would be happy to have a conversation or an email exchange about a specific client or patient to support that journey as well. And accompanying these sessions, we'll have some online written resources available on Craniofacial Australia's website that will be coming out soon too. Family supports, as listed here, are absolutely wonderful resources. It's so important to have that connection. So do reach out and contact these supports that are available if they're relevant to you. So I forgot to say at the beginning to put any questions in the chat. So do put any questions in the chat now, and I'll go through and try and respond to those if there are any in there. And I would also like to draw your attention to the QR code on the slide here for feedback, which I would greatly appreciate. I really value any feedback. And there's also a spot to put your email down if you'd like to be informed of any future sessions. So thank you in advance, and please do go on there. It'll only take a couple minutes to fill out. You can find me at Protea Therapy. I'm very happy to be emailed about any questions. I also have a very short wait list at the moment, but let me get to the questions. Thank you so much for these few weeks of information. So I was hoping to ask, as a community health speechy, what tertiary setting can we make referrals to if we suspect something structural or VPI? And oh yeah, great question. So it's going to vary depending on what state you're in, and also what location you're in. So typically the tertiary centers will have cleft speech teams. So I can speak specifically to Victoria because that's where I'm based. So there are two cleft speech teams, one at the Royal Children's Hospital and one at Monash Health. So if you are, depending on where the family is located, you can refer directly to the cleft speech teams. And then typically the speech pathologist will complete an assessment first, and then they would refer to any relevant they would refer on within that center as relevant. So there are at the children's, there's a VPI or cleft speech clinic where just speech pathologists will do assessments. And that would be if you're suspecting something, that would be an appropriate place to refer on. But I would definitely also encourage you to call or send an email and ask as well whether or not that referral is appropriate. Hopefully that answers your question, Wendy, but do put any follow-up. I'm going to just keep scrolling down. So put any follow-up into the chat as well. Oh, I'm so glad that the organizations have been helpful. That's really, really great to hear. Okay, well, I don't see any other questions, but do reach out over email if you have anything, and I wish you all the best in your journey. Thank you.
Thank you, everyone. And thank you, Dr. Boyce, for partnering with us for these last 4 webinars. It's been absolutely incredible. And just to echo what Dr. Boyce said, the videos will be available on our website. This one in particular, hopefully in the next 24 hours, will be uploaded. And a series of information brochures authored by Dr. Boyce will also be made available on our website. Definitely suggest following us on socials and subscribing to our newsletter to find out when it's all released. And we can't wait to see you all online, and thank you for joining us.
Thank you.
Have a good evening, everyone.
Bye.
Bye-bye.
Bye.